The widespread adoption of AI for medical guidance isn't happening in a vacuum. It's occurring within a deeply unequal healthcare system, and the patterns of AI adoption both reflect and potentially reinforce these systemic inequalities. Understanding this dynamic is crucial for developing policy responses that address root causes rather than just symptoms. Heavy reliance on AI for health information and medical guidance is often a symptom of inadequate access to traditional healthcare. When people cannot afford doctor visits, lack insurance coverage, face long wait times, or live in areas with provider shortages, they turn to whatever alternatives are available. AI becomes a free substitute for care they cannot access. This is adaptation to system failure, not genuine choice among equal options. The fact that millions of Americans need to consult chatbots for medical guidance because they can't see actual doctors is an indictment of healthcare system priorities and resource allocation. In a functional system, everyone would have reasonable access to professional medical care. The necessity of AI substitution reveals the system's functional failures, particularly for low-income populations, rural residents, and other underserved groups. However, there's a dangerous potential for AI adoption to normalize inadequate care for disadvantaged populations. If policymakers and healthcare administrators observe that people are using AI for health guidance and conclude that AI is solving access problems, investment in expanding actual healthcare capacity might decline. This would institutionalize a two-tier system where privileged populations have abundant access to human doctors, while disadvantaged groups make do with AI chatbots. This dynamic is not hypothetical. Throughout history, technological solutions have been promoted as addressing problems that fundamentally require investment and structural change. Rather than building more hospitals in underserved areas or expanding insurance coverage, it's cheaper to provide AI tools and declare the problem solved. But AI cannot substitute for the full range of medical services people need: examinations, procedures, diagnostic testing, emergency care, and the relationship-based longitudinal care that produces the best outcomes. The digital divide means that even AI-based solutions disproportionately benefit already advantaged populations. People without reliable internet access, current smartphones, or technological literacy cannot effectively use AI health tools. Rural areas, low-income communities, and elderly populations often lack the infrastructure and skills to access AI assistance, meaning these tools don't actually improve access for populations with the greatest healthcare needs. Data used to train AI systems reflects existing inequalities in medical research and healthcare delivery. Underrepresented populations have less data available about their health patterns, less research addressing their specific needs, and clinical guidelines often based primarily on studies of white, male, middle-class populations. AI trained on this biased data reproduces these biases, providing less accurate or appropriate information for marginalized groups. This means AI may work better for people who already have better access to care, widening rather than narrowing disparities. The costs of AI development and deployment ultimately get passed through the system in various ways. Insurance companies or healthcare systems adopting AI tools will incorporate these costs into premiums or service pricing. AI companies are profit-seeking entities that expect returns on their investments. If AI becomes embedded in healthcare delivery, these corporate profits represent resources extracted from the healthcare system that could otherwise support direct patient care. The question of who benefits financially from AI in healthcare matters for understanding whose interests are being served. Policy responses should use AI adoption patterns as data revealing access gaps rather than as solutions to those gaps. The geographic and demographic patterns of where people rely heavily on AI for health information map healthcare deserts and access failures. This information should drive investment in community health centers, rural health initiatives, insurance expansion, and provider recruitment in underserved areas. AI reveals the problems. Human healthcare capacity and access expansion solves them. Regulatory approaches should prevent AI from becoming an excuse to underinvest in actual healthcare. Any policies promoting AI tools should be explicitly coupled with requirements to maintain and expand traditional healthcare access. AI should supplement, not substitute for, human medical care for any population. Clear standards distinguishing enhancement from replacement would prevent the slide toward AI as a second-class alternative for disadvantaged groups. Community health centers serving low-income populations should receive resources to integrate AI thoughtfully with human care rather than having AI imposed as a replacement for inadequate staffing. The model should be AI helps community health workers and primary care providers extend their capacity, not AI replaces positions that should be filled by healthcare professionals. This requires adequate funding for both technology and the human workers who ensure it's used appropriately. Coverage expansion through Medicaid, subsidized insurance, or eventually universal coverage remains the most important healthcare access intervention. No amount of AI sophistication can substitute for ensuring people can actually see doctors, get tests, receive treatments, and access emergency care without financial barriers. AI as an information supplement to this comprehensive access is valuable. AI as a band-aid for inadequate coverage is unconscionable. The fundamental principle is that technology should reduce rather than reinforce inequality. AI in healthcare can do this if deployed as a supplement to comprehensive human care that reaches all populations. It will reinforce inequality if positioned as an adequate alternative to professional medical care for populations that the system has failed to adequately serve. Current trajectories suggest concerning movement toward the latter pattern, requiring urgent policy attention to ensure AI enhances rather than undermines health equity.